Good evening, everyone, and welcome to the May Conversations with a Doc. I'm Michael Walton. Sorry, Judy isn't going to be able to join us tonight, but Justin and I will cover the topic. Tonight, we're going to have Justin Martello, and he's going to be discussing deciphering Parkinson's disease medical lingo. At the end, we'll cover some pre-submitted questions, but if you have any questions during the webinar, you can ask them in the chat or the Q&A, and we'll address them at the end. So there you go, Justin.
All right, thank you. So, yeah, today I figured, a lot of times we give these different talks about Parkinson's disease, and I think we tend to try and do our best to, um, explain all of the different types of wording that we use and the kind of medical jargon that we use in our practice. But a lot of times, I think we tend to breeze over some concepts pretty quickly, and so some of these some of these slides you may have seen before if you've seen my previous talks before, but I did adjust them a little bit, and I do want to spend extra time on them because, again, sometimes a lot of us can go through it pretty quickly, and these are many times important concepts to be aware of, and even just if they sound complex or complicated, to break it down just so that whenever you're reading, one of your doctor's notes or your doctor is even talking to you and you're just not understanding everything quite well, this will at least help to arm you in a way that you'll have a better understanding of what they're talking about. So, again, like I said, I'm Dr. Justin Martello. I did work for the previous 9 years up at Christiana Care in Delaware. I'm now the new Regional Chief of Neurology for MedStar. I have an associate professorship at Georgetown University, which is all part of the MedStar Health system, and on the medical board for MAPS. All right. So I figured the best way to do this and go through the different type of wording is really to go through Parkinson's disease, right? Not only what it's about, progression, other things related to Parkinson's, because I think it can be very helpful, especially when you're talking about confusion with wording. Even among medical professionals, you'll deal with a lot of general neurologists even, but especially primary care doctors, emergency room physicians that will tend to use a lot of these words incorrectly. And so I think it is helpful for you to know the correct way to use these words and what these words actually mean. So, really quick, what is Parkinson's? So, and I'm going to kind of go through the slide and then we're going to kind of stop and go through the slide again because I kind of do this on purpose for some of the slides, giving kind of big words that may seem like I don't understand. You're trying to give us a talk about medical lingo and you're using really complex words, right? But we're actually going to break it down and we're going to go back. But basic 10,000 foot view, Parkinson's is a neurodegenerative illness. One of the major players in a lot of the physical symptoms is a loss of dopamine producing cells in this area of the brain called the substantia nigra. Typical physical features of Parkinson's include slowness of movements. You need to have that part of it. Then either the stiffness, the typical cogwheel rigidity, versus the resting tremor. We'll go into that. And then later on, balance impairment and lots of other physical and non-physical or non-motor symptoms. Kind of going back to that description, right? So, what is this area of the brain? What are you talking about, substantia nigra? So, this is kind of a slicing of someone's actual brain, obviously, after they passed away. And this is showing kind of what a normal brain looks like in this area or this region of the brain. It's called the midbrain. It's right above your cerebellum. And this is that area called Substantia nigra. It gets its word from the Latin or Greek for substantia, substance, nigra, black, a black substance. So these are the cells that produce dopamine. You can see with people with Parkinson's, they have a lot less of those cells. And we're going to get into this a little bit later about a DAT scan, but this just shows you again, not only is the dopamine producing cells down regulated or a lot less of them, but also the dopamine transporters, which use the dopamine, are a lot less too. And that's what a DAT scan does. So a DAT scan shows you the dopamine transporters in the different part of your brain that facilitates movement. And you can see in the Parkinson's patients a lot less of this kind of signaling that's showing up here. So again, stopping there, rewinding it, let's go through a couple things. So what does neurodegenerative mean? Neurologic disease. Degenerative means it's always progressing. And a lot of people will say, will ask me, well, is my disease going to get worse, or how much does it get worse? Or they'll even tell me, yeah, mine really hasn't gotten that much worse over time. So it is true that definitely people, especially with their physical symptoms, do progress in different manners. We do have, obviously, it's like a bell-shaped curve where you have the two ends of the spectrum where you can have some people, unfortunately, that progress super quickly, and we can talk about what that may mean. But also, there's the other end of the spectrum where people really don't progress that quickly over many, many years. Because it is a bell curve, those ends of the spectrum tend to be a lot less and a lot more rare. We're really dealing with the average, patients in the middle who will progress in a steady rate. There's usually typical rates that we think about, but I always like to say, and we see this in research, that if you can kind of plot out the way you've been progressing over 3 to 5 years, that kind of slope will kind of continue on out from there. A lot of things do affect that. Exercise is right now the only thing that we know of that can slow down the progression, so how active you are physically. And then there's other things that sometimes are out of your control, like medical issues, right? If you, God forbid, were to develop cancer, right, or a bad other medical issue, that would or can progress you faster. So there are different things that play a role in the progression, but everyone in general progresses over time. And then we talked about the DAT scan, means dopamine transporter scan. We're going to go into a little bit of the details a little bit later when we talk about testing for Parkinson's, and then again, lingo surrounding that. Now, this is a big one that I do like to harp on a lot in my talks because it is still something that many, yes, of course, patients, many caregivers, but this, again, the sad reality is many physicians and providers use this term incorrectly. And so, yes, it's Parkinsonism sounds like Parkinson's disease, but the best way I kind of use this, or the way this term should be used is kind of a really easy way to group a lot of symptoms that are typically with Parkinson's disease into just one word, right? And so the best way I equate this, as far as in other ways that we describe things in life, is if you see a friend, you said, "How are you doing?" I had a rough weekend. I had these like flu-like symptoms. I don't know what I had, right? Now, they didn't tell you everything about their symptoms, but you kind of understand what they maybe mean. Fever, body aches, chills, things like that. But instead of saying that whole list of symptoms, they just said, I don't know, I have like flu-like issues or I had cold-like symptoms, right? So this is the same idea. Parkinsonism just means that I have some symptoms that people with Parkinson's disease have, but it might not come from that, right? So this typical bradykinesia. That's what we call the slowness of movements, right? That's the fancy word for that. Cogwheel rigidity. This is a specific type of stiffness that people can get, which is different than a stiffness that like you may get with either strokes after a stroke or stiffness that comes with like arthritis. So it's not just any type of stiffness, but this is kind of what we call it in medical terms, cogwheel rigidity. And then this resting tremor. And we're going to delve more into tremor because, again, it's one of those terms that everyone thinks a tremor is a tremor is a tremor. And no, there's quite a few differences between different types of tremors, and or abnormal body shaking or what have you. So we'll get into that. But just to know that, as I put here, about 20 to 30% of people with Parkinson's may never have a tremor. So it's not with everyone. And then later on, balance issues for sure. That shouldn't come up early on in the disease. Sometimes it does for certain reasons, but mostly it's a later disease issue. Now, it may be true that most people with Parkinsonism have Parkinson's disease or have it because of Parkinson's, but that's really the question for someone like myself who's a movement disorder specialist who to say like, okay, there's so many reasons, and we're going to get into it actually into the next 3 to 4 slides. Not really to for you to study or know all the names of or even be worried about them, right? But this is where it starts to separate, and this is where you can see this confusion of to be honest, why my subspecialty and fellowship exists because there's so much to know as far as different causes of Parkinsonism that it's not as easy as, oh, you have it because of Parkinson's disease. So let's go into some of those causes here. All right. First, medications. So, not all these medications equally as far as their risks, but this is kind of a whole big list, especially on the left-hand side column there, where, yes, the most common medications that cause Parkinsonism are antipsychotics. Now, nowadays, antipsychotics have a lot more FDA approval and indications for other things that are not the typical psychosis diagnoses like schizophrenia or schizoaffective disorder. Now these medicines are being used. They're also called neuroleptics to treat bipolar disorder, just regular depression, anxiety, right? And so you may think, oh, I'm not on those medications because I don't have schizophrenia, right? I'm not quote unquote crazy or anything like that. But no, these medications are actually being used a lot by especially primary care doctors, but also other doctors, psychiatrists, things like that. So if you are one who has, long-standing history of depression, you've tried a few things, this may be in your history and it may be a contributing factor, right? It's funny, a lot of times the psychiatrist will consult us saying, all right, well, my patient's on a neuroleptic or an antipsychotic. How do you know it's not Parkinson's disease, right? How do you know it's only from the medicine? And what I'll always tell the psychiatrist or the primary care doctor is it almost doesn't matter because it's either one of two things. It's either all from the medicine, right? Or, yeah, maybe they do have underlying Parkinson's disease and those medications are making them way worse, right? And so just to know that that is a big category that we look at for causing Parkinsonism. And that's mostly because not only that class of medicine, a lot of these medicines on the list can have effects on blocking the dopamine system. And as I mentioned before, Parkinson's disease is all about dopamine and it being lowered in your system. So if you're having medicines that's blocking the dopamine effects even more so, then that's going to make things worse, right? Now, there are some safer neuroleptics or antipsychotics, quote unquote, safer ones that come to mind. Actually, there's really just two of them, Seroquel or quetiapine, and then clozapine or Clozaril. Those are the two kind of quote unquote safer ones in the setting of Parkinson's. The next big class of medicine, definitely people tend to miss, is antiemetics. What are these? These are nausea medicines, anti-nausea medicines. Now, all of the anti-nausea medicines, with the exception of one, and I included there Zofran, the generic is ondansetron, will block dopamine, right? And so this tends to come up, especially in Parkinson's disease, because a lot of people with Parkinson's develop issues with their whole GI system slowing down. A lot of times we talk about and focus on the constipation, but we don't often talk about the slowing of the stomach, what the GI doctors call gastroparesis, right? A slowing of kind of food and drinks and everything getting moved through your stomach. People get bloated. They feel like they get filled pretty easily. And this could be a really big problem. Well, the main treatment for this in other conditions that cause gastroparesis are these antiemetics, right? All these are these anti-nausea medicines that can promote your stomach to speed up. But as I mentioned, they can definitely worsen and usually do worsen the physical motor symptoms. So something that we don't want you on if you have Parkinson's disease. Other things that can be common, amiodarone, it's a medication for atrial fibrillation or AFib. Now, many of my patients are on amiodarone who have Parkinson's because many of them tend to have AFib. More coincidental, as you get older, you're more likely to have AFib. So it's not like it's a medicine you can't use, but it is a medicine that can contribute to tremors and Parkinsonism and balance issues, sometimes cognitive issues. So while it can be a very good medicine for AFib, sometimes we want to have a second thought and maybe other choices or other options from the cardiologist. The next few medicines are maybe not as common. Reserpine really not used anymore. Tetrabenazine, valbenazine, and deutetrabenazine are all VMAT2 inhibitors. They're used to treat tardive dyskinesia. Now, I didn't put this on the slide. Something that's really important. A lot of my patients have come to me saying, "Hey, I think I have tardive dyskinesia," right? They will see the commercials. There's a lot of commercials nowadays for Austedo or Ingrezza. Those are the two new VMAT2 inhibitors that treat these. What is tardive dyskinesia? Tardive means late. Okay. Dyskinesia is just kind of an abnormal involuntary movement, and which happens as a late effect, tardive, to antipsychotic exposure, right? Yes, and we're going to talk about this. Parkinson's disease causes dyskinesias specifically from the dopamine medicines like levodopa, or at least they can happen from those all the Parkinson's medicines. But that is more of a reflection of the dopamine being a little bit too high of levels, usually in the system, and usually from having the disease for a long time. But if you were never on the neuroleptics or antipsychotics, it's not tardive dyskinesia. It's just regular dyskinesias from the Parkinson's disease. And so you actually would not want to be on one of the TD or the tardive dyskinesia meds right here because it'll worsen your Parkinson's. The last three, much less common, much more rare of a cause of Parkinsonism. So, Depakote, often used as a seizure medicine, sometimes as a mood stabilizer medicine. Calcium channel blockers used for blood pressure issues, and lithium used for mood stabilizer. Much, much less common of a cause. Then you go to the right-hand column, a lot of different toxins that we're learning about. This is just kind of a brief overview. You see the second bullet point there being occupations that tend to contribute to a risk of Parkinsonism and sometimes Parkinson's disease. This is not an exhaustive list. There's a ton of chemicals. The biggest one I didn't actually have up here is paraquat, found in a lot of pesticides and things like that. We're learning more and more about all these different risk factors for toxin exposures. I will tell you, though, that even with the highest risk right now, which would be, again, something in existence still in a lot of our products, paraquat, it's still something that's been very hard to tie in with 100% of the cases of Parkinson's because the risk factor is higher, but it's not like super high. It doesn't nowhere near match the levels of, let's say, tobacco use and lung cancer or asbestos and mesothelioma, right? Those are like really highly linked, exposures to diseases. Even paraquat maybe increases your risk 2 to 3 times, but that's 2 to 3 times based off is still a very low number. And so we're still trying to figure out, and we'll talk about some theories of maybe why some people get it with these certain exposures and some people don't. There's, again, many other things that can cause Parkinsonism. One of probably the second most common reason is vascular Parkinsonism. This is when, so a lot of people talk about kind of vascular disease or heart disease affecting or developing plaques in the heart vessels. Well, the same thing can happen in your brain. And just like your heart, where you can have either a heart attack, which is like immediate, something you feel immediately, you can also develop heart disease very slowly over time. Same thing with the brain. You can develop an acute blockage with a clot that causes a stroke, or a very slow buildup of plaque and damage over time. And this can contribute to what we call cerebral vascular disease. So, cerebral meaning the brain, vascular meaning of the vessels, and it can cause slow kind of decay and destruction of your brain cells over time. And this can mimic or cause, again, the Parkinson's physical symptoms without it being Parkinson's disease. I don't want to necessarily go down all of them, just to know there's a lot of other diseases that can cause it. We're going to circle back to the one in italics there, the normal aging, because that's always interesting to talk about. Finally, before we get to normal aging, these are all the other diseases, right? And again, I think I could probably do another 3 slides about this. I just want to highlight a few things here. The ones in red are what we call the Parkinsonian plus syndromes, right? Some people call them atypical Parkinsonism, but this is kind of what we talk about. These are kind of cousins of Parkinson's disease, but usually much worse, much more rapidly progressive, much less responsive to medicines. And again, not that we're going to go into them tonight, but just so that you know their names, their abbreviations. So, progressive supranuclear palsy or PSP, multiple system atrophy or MSA, cortical basal degeneration syndrome or CBS, and then Lewy body dementia, LBD or DLB. And then also Alzheimer's disease, Alzheimer's dementia can have Parkinsonism associated with it, along with frontotemporal dementia. So again, lots of things can cause Parkinsonism, which again, just to be careful when you hear either other doctors saying, using that word, and sometimes they won't even use it. Sometimes they'll see it on your chart, and then they'll just say, "Oh, you have Parkinson's disease," right? I try and be very deliberate with this term in the way it's used to. So a lot of times, if you're reading my note, if you're a patient of mine, or even other movement disorder specialists, and you see that we have coded as far as the diagnosis, Parkinsonism, many times that's because we're still trying to figure out why, right? So I'll put that there as a way of saying, okay, you have these certain symptoms, physical findings on your exam. We're still trying to figure out why you have Parkinsonism, and so I'm just going to put it there, right? It's almost like saying, I'm putting cough as your diagnosis, right? If I still don't know why you have the cough, if it's medication induced or an infection or whatever, I'll just put that there as a way to say, still trying to figure this out, still trying to work this out. All right. And then we get to normal aging. So this was a study that was done, now at this point, 30 years ago, but I think it still is something that rings true to what we see in human development. But this was a group of patients who were followed over time and looked at different age groups. And we did our normal kind of movement exam to see, and this was a group of patients that definitively did not have Parkinson's disease, but how much did they look like someone who had Parkinson's disease? How much all of the different age groups had Parkinsonism as a part of normal aging? And you can see here it does go up over time because you can imagine, or you are living it, that as you get older, you have other reasons to be stiff, as I mentioned, right? Arthritis, spinal disease, other orthopedic injuries. There's reasons to be slower. You're not maybe as active, you're slowing down, everyone slows down as their body ages over time. There's other reasons to have tremors as you get older. So, just to kind of illustrate that this tends to be another question that we get is like, how much of this is just normal aging or is this underlying Parkinson's? So, testing. I want to go into this just because, again, when doctors start talking about workup, again, we can go through a lot of these terminologies without really explaining them in a good way, and you need to really know, all the options, the explanations of them, and so I think it's helpful. Many times you will find that the first person you see is either the primary doctor or a general neurologist, and they'll typically want to get an MRI of your brain. That's not necessarily wrong. It's only something that, again, depending on the amount of time you're waiting to see a movement specialist, it doesn't tend to give you the answer most of the time. Now, there are times when maybe you have something really weird or not typical with your story or your symptoms or your exam, right? And then that would definitely be a reason to start with an MRI. But with most times, if you're looking to be going the direction of Parkinsonism and someone who has typical Parkinson's disease, many times we actually don't need to get any of that testing. Like I said, it's not wrong. It's more about, and if you are seeing, or if you are able to see a movement disorder specialist in a relatively short amount of time and not a lot of waiting, maybe you hold off on testing just to say, I want to see what they say, right? That's actually not wrong. There's actually many things that I wouldn't say that about, including medication trials. A lot of the primary doctors and general neurologists are well equipped to start you on medications to see if that helps. And we actually advocate that in a lot of cases. But testing is something that usually we can afford to wait on. So that's when we go to really the two, in really the realistic world of testing for Parkinson's, which most of the time we don't need because most of the time, especially for someone like myself, a movement disorder specialist who sees 8 to 10 Parkinson's patients a day, we are able to tell the subtle differences of your exam findings, your historical symptoms and progression to really diagnose you clinically. All that means is we don't need any testing to diagnose you. And we're pretty right most of the time. There's actually a lot of studies on this, on how correct we are. But we get even better because a lot of times, especially before we had this kind of imaging or testing, we would start medications. And if you should improve in a pretty dramatic way with the medications, especially carbidopa levodopa. And if you do, that kind of clinches the deal. And that helps us with the kind of testing for Parkinson's. We can also follow you over time and see how you change over time, and that can help us to say, huh, you're progressing a little bit faster. You didn't really connect or do well with the medications. Maybe we're dealing with one of the cousins or one of the Parkinsonian plus syndromes. But we do have two tests now, right? A lot of people do like that we had that option just to be more clear about the diagnosis. I will say that both tests are still not perfect. The only way to be 100% sure, unfortunately, is still autopsy, right, after you pass away. Uh, but we'll talk about how good the testing are while you're still alive. So dopamine transporter imaging, the DAT scan, we kind of illustrated that before. Technically, the FDA indication is to distinguish Parkinson's disease or Parkinson's tremor from essential tremor. And we'll talk about essential tremor too in a few slides. Um, I will tell you, we normally do this for other reasons. One reason we don't do this test is for disease severity or prognosis. So a lot of times we'll get it, and let's say it's abnormal, indicating you have Parkinson's, or I should say one of the Parkinsonian syndromes, and we'll talk about that in a second. But the next question we usually get from patients is, oh, well, how bad is it? What stage am I in? How fast is it going to progress? And we don't get that answer from a DAT scan or the other test. Both of the tests that we have available are really just yes or no answers. Do you have one of the Parkinsonian conditions or do you not? But many times, as I alluded to before, we actually get the DAT scan for other reasons, right? As I mentioned before, how much of maybe a medication you're on could be contributing to the Parkinsonism versus underlying Parkinson's disease. So any kind of medication or drug-induced Parkinsonism, vascular Parkinsonism would be normal, normal pressure hydrocephalus. Other diseases is actually more common that we're trying to differentiate. Now, as I again somewhat alluded to a second ago, a DAT scan will be abnormal in all of the five Parkinsonian conditions. As I mentioned before, yes, Parkinson's disease is by far and away the most common, but then you have those other four that were in red a couple slides ago. Those will also be abnormal. So, yes, there are usually, other symptoms or exam findings or the way you're progressing or doing with medications that can help differentiate between these five conditions. Sometimes it's hard in the beginning. Sometimes they all look the same. And then only later do we get a better sense of how you progressed, how you did with medications, the development of other issues that we say, you know what? I thought you had Parkinson's, but it's really going down this other path. And that's not uncommon, even for movement disorder specialists, because again, it can look the same in the beginning. Um, so just for you to know that there is about a 10% chance that it could be falsely normal or falsely abnormal, right? And that's where this 90% sensitivity and specificity comes in. All that means is it's right about 90% of the time, but it's wrong about 10% of the time in both ways, right? In both the false positives and the false negatives. And the reason for this is a DAT scan is a picture, right? And so, and it's very funny because wherever you go to get the DAT scan done, and I don't care if it's at Hopkins or Franklin Square, where I'm mostly working out of, or Christiana and in Delaware, the nuclear medicine, so it's a nuclear medicine scan. All the nuclear medicine radiologists will always say it was a perfect test, and it's definitely abnormal or it's definitely normal. And then I will always look, and the movement disorder specialists look at the image and we're like, I don't know, that looks mostly normal, but a little bit abnormal. Or that looks kind of abnormal, but not that bad, right? So that's where the kind of 10% risk comes from, that it's not a calculated test. It's more of something that you look at to see if it's symmetric and fully kind of developing the whole area of the transporters all the way, right? So there sometimes can be issues with insurance and costs with this test. Not so much recently, but it can still happen. Then the other main test that we have is called the Syn-One, Syn-One test. You can see the picture in the bottom right hand corner. This is a skin biopsy that we do. Many of the clinics do who have movement disorder specialists. We take a sample of your skin at three different areas: around the shoulder, around the knee, and around the ankle. Really small punch biopsies. And then we send it to a lab to look for specific abnormal protein buildups, which we're going to talk about later, called Lewy bodies, right? And I know a lot of people talk about Lewy bodies and Lewy body dementia. We'll talk about the differences there, but so we're looking for Lewy bodies in an alpha-synuclein, which are Lewy bodies. So buildup of abnormal clumps of alpha-synuclein as in a Lewy body. That's where it kind of comes its name from in the skin cells. And so that can show up pretty early in the disease progression. Now, for that, if it is abnormal, it is pretty accurate. So what those numbers mean, so let's go to the second one first. So 95% sensitive. What that means is that there's only a 5% chance of being falsely normal. When you look at that 100% specific, what that means is so far, and there's been maybe one case report that this was not true, but almost like 100% of the time, if it's abnormal, you have one of these diseases that are in the parentheses there, right? Parkinson's disease, PD, MSA, Lewy body dementia, or primary autonomic failure. You have one of those, what we call synucleinopathies. These are diseases that involve the buildup of abnormal alpha synuclein. Alpha-synuclein is a protein. It's an abnormal protein that most bodies who have a functioning, let's just say, garbage disposal system can get rid of these abnormally folded proteins in your body. Well, for whatever reason, and we'll talk about the maybe the causes, of some people with Parkinson's, whether it's genetic or environmental. For some reason, that garbage disposal system that gets rid of and processes these abnormal proteins just stops working. And so this group of abnormal protein called alpha-synuclein starts to build up into these clumps, into these Lewy bodies. I'll show you a picture of it later. And then these Lewy bodies start to accumulate in different cells and starts to cause in different areas of your body, and starts to cause dysfunction in those cells, which again gives you eventually the loss of the dopamine producing cells, and other symptoms as well. So this test can be cheaper. There's been some more recent issues with insurances with this where it may not be that cheap as we used to have it. And then with the only other downside is that with the procedure, there's a longer turnaround time for an answer. So most clinics can get you in, maybe 4 to 6 weeks to do the actual skin biopsy, and then it takes another 4 to 6 weeks to actually get back the results from the skin biopsy. Now, I do want to take a couple slides talking to you about tremors and how, again, not all tremors are created equal and how we have different terms for them. So, the most common tremor that anyone can get is called essential tremor. Essential tremor tends to happen later in life. There is a group of people who can get it earlier in life for sure, even as young adults. And essential tremor is the tremor that happens when you're holding something or using your hands, right? Most of the time, it's pretty equal in both hands. Sometimes maybe worse in one hand versus the other. It can be dominant, non-dominant. But it's always when you're using your hands versus when Parkinson's tremor usually is at rest. And a lot of people confuse what does that mean, rest, right? We mean your hands are in your lap. You're not thinking, you're not contracting your muscles at all. You're not tense, right? You're really at rest and they shake on their own. And I make that point because a lot of people with essential tremor um, can have some anxiety issues too. And whenever you're contracting those muscles, even though they look at rest, they can start to shake. So it can look like a resting tremor. But if you're tense or if you're holding something or if you're purposely kind of pushing your hand down in your lap and activating those muscles, that can cause a tremor. The other confusing thing can be that people with essential tremor for many years can start to develop a resting component. And so again, obviously this is why my subspecialty exists, to kind of figure out these subtleties. I like to, in the movement world, we always like to show videos, and I do want to point out that there can be other types of tremors that we see too. Now, both of these individuals have Parkinson's, but I want to point out kind of their tremors here. And again, typically, again, this is a resting tremor with Parkinson's. Most of the time, it's worse on one side of the body versus the other, especially in the beginning. Now, you can see when she puts her hand up, they're actually still at first, but then it reemerges, right? It was steady at a posture, and then it reemerged out of a posture. So this is what we call a reemergent tremor that can come with Parkinson's. People with essential tremor, as soon as they raise up their hands are going, right? And so again, just to illustrate, not all tremors are created equal. Again, you see this asymmetric resting tremor, what we call sometimes a pill rolling tremor. And you can see initially the posture, right? He's pretty still. And then out of that posture, it starts to reemerge, right? Again, this is kind of a table comparing the two, ET and PD. Usually, ET is very slowly progressive over time. It doesn't include other associated issues like slowness of movement, stiffness, obviously, that the Parkinson's can have. People who have essential tremor for many, many years, if not decades, can sometimes eventually develop balance issues, but more often the balance issues are with Parkinson's. And so we kind of went over the rest of these things. Now, talking about the differences uh, from PDD, Parkinson's disease with dementia versus Lewy body dementia. And again, this is one of those things that people throw around all the time, not just patients with Parkinson's, but also not just caregivers, but also general neurologists and primary doctors too. Okay, we want to be very clear about this, right? Now, there are a lot of similarities, and I will tell you, you can have two people in the room, and all you had was their exam findings, what they looked like, right? And so their symptoms, and they could sound the exact same between the two of them. The difference, the big difference, I will say, and we'll go over some differences between PDD, Parkinson's disease dementia, and Lewy body dementia, is that the Lewy body dementia person will say, I have all these issues and I've only had the disease for 3 years. The Parkinson's disease dementia will say, I have all these issues, but I've had Parkinson's for like 10, 15 years, right? So definitely is something where LBD, Lewy body dementia, is much more rapidly progressive and includes early issues of dementia and psychosis. Before we get into this further, so they both can show MCI, mild cognitive issues, mild cognitive impairment. Very common in both, right? And so when we talk about the differences between mild cognitive impairment and then dementia, so a lot of people is like, well, do I have dementia or do I have Parkinson's, right? Um, just think of dementia again as more of a broad topic, right? So you talk about dementia, then you have different types of dementia. Just like if I said you have an infection, you would say the next question is, okay, what type of infection, right? Same thing with dementia. You have dementia. Okay, what type of dementia? Well, there's Alzheimer's dementia. That's the most common. There's vascular dementia. We talked about vascular Parkinsonism, same idea. There's Parkinson's disease dementia, there's Lewy body dementia, there's frontotemporal dementia. There's a lot of different dementias. Dementia just means a problem with one part of your brain that deals with cognition, whether it's memory, word finding issues, or math equations, or speech, or visual spatial issues, or executive functioning, higher level thinking. Different parts of your cognition are affected in different ways with these diseases, right? Now, they both include abnormal accumulations of alpha-synucleins as Lewy bodies. And you can see the picture right there. This is kind of what a Lewy body looks like. But they tend to have the distribution of these Lewy bodies in different parts of their brain, which is why we do understand them as two distinct diseases. So it's not like you go from Parkinson's disease and then you develop Lewy body dementia. It's either one or the other. Now, there is, yes, as with all things in life, usually it's never 100%. So, yes, does there maybe exist a rare patient who is kind of right in between having Parkinson's disease dementia and Lewy body dementia, and it's not very clear they have features of both? That can still happen. Super rare. It's either you always had Lewy body dementia or you always had Parkinson's, right? It's not first one, then the other. And as I mentioned before, Lewy body dementia, very faster progression. Early, and when we say early, meaning within the first few years, gait imbalance issues, autonomic dysfunction. We're going to get to this, but that means the part of your nervous system called the autonomic nervous system that controls everything you don't think about, from blood pressure regulation, heart rate regulation, GI movements, urinary issues, erectile dysfunction, sweating changes. Like that's your autonomic nervous system. Dementia early on. This is a big one, fluctuations in attention arousal. So these people will kind of be awake and then they'll be kind of sleepy during the day and then back awake and back sleeping. And that can describe people with Parkinson's too, but this is tends to be a little bit more dramatic. And then their Parkinsonism, their motor symptoms are usually on both sides of their body. Then this is the biggest one. They need the psychosis, which is the hallucinations, delusions, and illusions. And that's a typo there for hallucinations at the end. Within the first year of motor symptoms, right? So, like I said before, with Parkinson's, can you have hallucinations? Yes, we'll show it in the next slide for sure. But that usually happens way in the future, right? With Parkinson's disease, usually at least 10 to 15 years out. Sometimes a little sooner than that, but most of the time. Versus with Lewy body dementia, that's happening within the first year of your Parkinsonism motor symptoms, right? So it's usually very clear one versus the other as far as developing that. Now, this is the typical progression for someone with Parkinson's disease in general, right? As I mentioned before, it's kind of a linear progression, but we're going to kind of break this down a little bit, okay? So, just to orient you, the x-axis at the bottom is kind of time in years, where the center of the graph is time zero. We'll talk about that. And then the y-axis is degree of disability. So, how bad are things getting? And then you see different colors here. The light blue at the bottom is kind of what we call the non-motor features. We'll talk about that. Then the kind of darker blue is motor features, and then the last is complications. All right, so we'll start from the beginning. So we know that there are a certain set of non-motor symptoms that can be present years, if not decades, before the disease starts. That's why whenever we talk about when did your disease start, we talk about when did the symptoms start, because that's not really when the disease started, but that's the best way we can tell like when time zero is, because we don't know how many years you had it beforehand. This does make it difficult for research to develop medications that slow down the progression or stop the progression, because a lot of the time the damage is done by the time we quote unquote capture it with physical symptoms. So, what are some of the terms here? What's RBD? RBD is REM sleep behavioral disorder. This is the issue. Again, not everyone, but many people with Parkinson's have where they start to punch and kick in their dreams, start to act them out. And it's more than just like talking in your sleep or shouting. It's usually it tends to be a little bit more violent. Not all the time. Sometimes it can be rare, but this tends to be one of the early signs of Parkinson's. EDS, excessive daytime sleepiness, somewhat non-specific, right? A lot of people say when I get older, I feel really tired a lot, really fatigued, really sleepy during the day. Hyposmia or anosmia is the decreased or lost of sense of smell. A lot of people say, I had that for like 30 years. I lost it when I had a bad sinus infection, or I used to be a heavy smoker and I lost it with that, or, nowadays with COVID, right, I lost it with that. But guess what? Even though those things may be true, that doesn't mean the Parkinson's also wasn't starting way back then too, right? So just to be aware, that's a big sign. And a lot of people are worried, especially with COVID doing it. But to be honest with you, we have known for a long time that other infections, including just the typical flu, influenza virus, can also have done that in the past and can also increase your risk of Parkinson's, right? So there's nothing new about COVID. Yes, COVID was obviously much more spreadable and early on maybe a little bit more deadly than obviously the typical flu, but it has always been coronaviruses and influenza viruses and other viruses that can take away your sense of smell and can increase your risk of certain neurological diseases down the line, including Alzheimer's, right? And so again, it's so hard to point out one when we've known that this has been a risk factor for a long time, and there's nothing you can do about it, right? I mean, infections are a part of life, like it is what it is, and so it's more about just something to be aware of and to be just no, no, for right now, we don't really, we can't really do anything about it because the alternative is obviously never leaving your house or never doing anything, which we know will make you much, much worse in a number of ways. So that alternative is not a good answer. MCI, we talked about this, mild cognitive impairments, so just mild issues with maybe short-term memory, word finding, things like that. Orthostatic hypotension, we talked about the autonomic nervous system, right? Again, urinary symptoms are there. Orthostatic hypotension is when your blood pressure tends to drop when you stand up. Most of us with intact autonomic nervous systems, when we stand up and gravity pulls our blood down into our legs, we have mechanisms where the veins contract and push the blood back up into our heart and our brains. Well, for a number of reasons. People with Parkinson's disease lose that ability, and so they can have wide fluctuations, even if they're not standing or walking, but especially when they do, in their blood pressure, right? This is, you usually do know you have this for a number of reasons. One, it's always something different when you check it either at home or at the doctor's office, or you tend to get really dizzy or lightheaded when you walk around, or really tired when you stand up, or off balance. That's a good sign that that's happening. Dysphagia, so what this means is difficulty swallowing. Most of the time, if it does happen with Parkinson's, it starts with liquids first. As you age, you can develop issues with swallowing solids as a change in your esophagus. That's completely coincidental and not related to Parkinson's. And actually, if that happens, there is a correctable way through seeing an ear, nose, and throat doctor or ENT doctor that they can fix that. Unfortunately, with the type of dysphagia that happens with Parkinson's disease, it is not fixable. There are ways to maybe improve your swallowing, but there's no kind of correctable way for it. Motor fluctuations. So we talk about this a lot in the movement disorder world and with progression in Parkinson's. So just to orient you to this graph, again, x-axis is time. This is typically, let's just say, over a day. And then the y-axis is brain dopamine levels, with that white line being how high your brain dopamine levels are going with taking something like carbidopa levodopa, which is still our mainstay therapy for Parkinson's disease. So you can see that anytime when that line is kind of in the dark red area underneath, that means it's not helping your physical motor symptoms. Taking a step back, a lot of people will say, I don't know, what are you talking about? Like, I don't even know why I'm taking this medicine, right? Well, time out. That should be something that you know the answer to right away, right? I always say with all of our medications for Parkinson's, you should know exactly why you're taking them, each and every one of them, right? Because unlike most diseases where your doctor will say, oh, you have this disease, you have diabetes, you have to take a diabetes med, sorry. This completely different because all of our medications do not slow or stop the disease progression. They're not just good for the disease. All of our meds treat symptoms and improve quality of life by treating symptoms, right? So literally, this should always be a conversation with your doctor. Doctor, I am having this problem or this symptom or this issue or this physical complaint. How do I fix that? It should not be me as the doctor saying, hey, you need this medicine for your Parkinson's. No, wrong answer. That should never be the case, right? So now it is true that some people, even patients of mine, will say, I don't even remember why I'm taking this. Like, I don't even remember what you said, or I don't even think it ever did anything, right? Now, for hopefully if the doctor will take good notes and they'll look back and they say, "Oh no, remember when we started this? You were having either a lot of tremor or you felt really weak and stiff on that one your dominant hand and it wasn't really flexible, and now you're moving. And then we started and you were moving a lot better. You feeling a lot better. That's what it was there for." Oh, you're right. I do remember that when I do miss a dose of my medicine, or maybe a couple doses of my medicine, or I'm late for my medicine, the symptoms do kind of come back. I feel kind of worse with my walking and balance, or whatever it may be, right? So have first a clear understanding of what does it feel like for the medicine to work. That is what we call the good on time, right? Anything in this green area, that's when the medicine's working great. You feel great for your symptoms. Anything above it, you're having dyskinesias, right? That's the abnormal kind of writhing motions. Could be of your body, could be of your head, it could be of one hand. And it doesn't always have to be bothersome, but this is kind of what we talk about with the troublesome or bothersome dyskinesias. And then everything below that is your off time. So this is like the on time, off time. Is the medicine working? Do you feel on? Or do you feel off and the medicine's not working, right? And as the disease progresses, this window, this is what we call this therapeutic window, or the window where you feel really good with the medicine, no matter what the dopamine levels are, that tends to narrow over time. And so it's harder to skirt that sweet spot of the therapeutic window as the disease progresses. And that's why you see a lot of times people like Michael J. Fox, who's had the disease for over 30 years now, who's has dyskinesias all the time. People will ask him, first of all, he doesn't even know it half the time, and they can be pretty violent, right? But also, he says, well, listen, right now, my therapeutic window is so small. It's so hard to get my levels into that area without it going too high or too low that right now I only have two decisions. I either can be stuck, slow, and feel like I'm in a box, I can't move at all, or I move too much. And I think for most people, and it's funny, we have a saying that people who worry about dyskinesias are those who don't have them yet, right? That they see other people with dyskinesias and they, maybe rightfully so, get a little, um, disconcerted about that, right? But I will tell you, everyone who has dyskinesias, yes, it may be very bothersome to them, and yes, there are many ways now that we have to avoid dyskinesias, right? So that's good. But at the end of the day, when they're either faced with two options, and again, hopefully we never get there with most people, and we don't, but if you only had two options, let's just say, move too much or move too little, most people would rather move too much than move too little. All right, stages of Parkinson's. So I just wanted to mention this because I think it's helpful as a way. A lot of people ask us about this. Yes, there is a typical um, staging system of Parkinson's called the Hoehn-Yahr Parkinson's or the H&Y scale. This is what it looks like. There are five levels. You can read them through. I will just tell you that we don't find them very helpful clinically. They're really more helpful in research. We don't find them helpful clinically because they don't really mean much to what your progression or your prognosis will be. Some people can go from stage one to stage two like that, and then stay in stage two for like a decade, right? So while this was created, it's very archaic at this point, and so I just bring it up here just for you to know that that exists in case anyone asks about stages really nowadays, and it may seem less scientific, right? But I think something that it's easier to grasp not only from patient, caregiver, but also physician talking to physician. It's really just more broad, mild, moderate, advanced, severe. Mild, yes, you may definitely be having symptoms. They may be mildly bothersome, but they're really not affecting your daily life. You can still function. Moderate, they're becoming more bothersome, maybe affecting some certain activities, like more advanced activities like your work, or more advanced fine motor activities. Advanced is when you're starting to have these motor fluctuations, right? Where during the day you feel like the medicine wears off, or it takes a while to kick in, or you start having dyskinesias. Maybe your balance and gait is starting to be affected. And then severe would be, yes, you're really depending on others now for your activities of daily living, like dressing, bathing, um, what have you. And so, eating, and a lot of times you're using some form of cane walker to walk around, and we're using advanced therapies. We're using lots of meds. And just for the sake of time, and I want to leave time for questions. Um, this is our current landscape of medications. Lots of options. That's a takeaway here. They're divided in different categories just for the way that they work. But the great thing about a lot of these medicines is they work with each other. They're not duplicative. So you could be on, and the unfortunate nature with Parkinson's and the dopamine system is sometimes people need to be on a lot of different types of medicines attacking, and I say attacking, but obviously working with your dopamine system at different levels to make it so that you can move better, right? So a lot of people, the sad reality, but the reality is that a lot of people need a lot of different medications with Parkinson's because it affects so many different parts of your body, almost every organ system, to be honest. And not one of these medicines hits all of them. These are all the medicines for like your physical features. But what about all those non-motor features I told you about before, right? Anyway, takeaway, lots of options. Couple other quick things. There is something that's called adaptive DBS now. DBS is just deep brain stimulation. It's one of the technologies we have for advanced therapies for especially tremors, but other kind of motor fluctuations. DBS is just kind of a pacemaker to the brain to help with the different physical symptoms of Parkinson's. Now with the newer technologies that uses sensing, brain sensing, and AI, it can adjust the levels in your brain for how strong the stimulation is based off how your symptoms are doing throughout the day. This was approved a little over a year ago. I think the jury's still out for how well it can help in the future, my hope and the hope of everyone is that eventually it will adapt fully so that we don't have to program you at all. It will learn from your brain waves what kind of sensing programs it needs to deliver to help with your physical symptoms. This is kind of the graphs that we see on our programmer for that. I've talked about focus ultrasound a lot. It did get a new approval. So FUS or HIFU or MRI guided focus ultrasound has now have a new approval for Parkinson's disease symptoms and motor fluctuations. There are a number of sites doing them across the country. Hopefully, we will be getting the machine and I will be trained in it by the end of the year, but something to be aware of. Not only does it help now for tremors, but other things as well. And then for the sake of time, I'm going to skip my last couple things. Um, Maybe we'll get to them in a different talk. But it was a lot. It was a whirlwind of things. But I know we have some questions, Michael, that were already submitted. I don't know if anyone else submitted other questions.
Yep. Yep. I'll go ahead and do our pre-submitted questions first. And if anyone has any other questions, feel free to either raise your hand or ask in the chat or the Q&A. So let's see here. Our first question. My mother is a 75-year-old suffering from dermatomyositis. Sorry, that's a long one for me.
Let
And
me see.
atypical.
Let me see if I can get it. Dermatomyositis and
That's
atypical
it.
Parkinson's. There you go. Since
Yep.
2 years, she's bedridden and on I guess that meant probably peg feeding. Is there any new medication for atypical Parkinson's? Yeah. So again, as I mentioned before, atypical Parkinsonism, sometimes people use that word differently, right? And sometimes they mean the Parkinsonian plus syndrome. Sometimes they mean some Parkinsonism disease that doesn't fit nicely into any of the boxes. And so it's hard to say if there's just one medicine for that. Unfortunately, whether or not you're talking about the Parkinsonian plus syndromes like PSP, MSA, Lewy body, CBS, there are not any new medications for them. We're getting very close with some in research, but the short answer is no, there's not.
All right. Next, we have how to manage the transition between one prescription to another in patients with Parkinson's disease after they're 80 years old.
Yeah, so kind of a broad question, right? I mean, I think we definitely have considerations for older people in that list of medications that are available in Parkinson's. It is true that, at least for right now, this may change in the near future with a new medicine being released, hopefully later this year, that dopamine agonists like Mirapex, pramipexole, ropinirole, Requip, or the Nupro patch, people who are over the age of 70 can be more sensitive to their side effects and something that we try to avoid. And there are other medications like that as well. So it is true that when we're dealing with older patients, a lot of those options are really not good options anymore. But it is always something that whenever we're transitioning patients from one medicine to the other, there are different ways to do it. And age doesn't always tend to play a role in that. And so I wouldn't be that concerned about that, especially if you're being managed by a movement disorder doctor.
Very great. Okay. How hereditary is Parkinson's, and is there an identifiable gene?
So yeah, so we didn't get a chance to get to there, but in Parkinson's disease, we know that about 10 to 15% of people with Parkinson's have a clear family history, right? And a clear genetic link of their Parkinson's. But what about the other 85% of people who don't, right? And that's where this not just theory, but I think this understanding that we do know that there are a lot of genes that are implicated in the risk of Parkinson's. And so what happens, or what we think happens, is you may have some gene that's implicated in risk for Parkinson's, and under the right environmental setting, develops Parkinson's. Meaning, as I mentioned before, pesticides, right? Well, obviously, if you're a farmer or live around farms, or yes, there's been the new article about golf courses too, right, with pesticides, that you're at a higher risk of developing Parkinson's. But not every farmer and not every person that grew up around or lived around or lives around golf courses develops that, right? So why is it only some people and not everyone? And that's where this combination of do you have a specific abnormal gene that in this right setting turns into Parkinson's, right? So it is true that we are starting to look more into gene trials because, maybe it's the case where this one gene didn't really affect you enough, and maybe it was environmental factors, but maybe because you have that specific gene, we can really say that you're a part of this subset of people with this gene, and maybe medications that slow down the progression will work for you. So by grouping everyone into this one bucket in research, maybe that's why none of our medicines have shown to work because we're lumping too many people that are really somewhat different, right? Yes, they all have this disease that shares similarities, right? But why is it that some groups of patients develop it at an early age, some at a later age, some have tremor, some don't have tremor? And so we are starting to do a better job of saying, let's not just research this medicine with everyone with Parkinson's. Let's research it in these specific types of groups with either a specific genetic abnormality or specific symptom for that.
Great. Uh, some more came through on the Q&A. So we got one. It seems that Parkinson's causes fatigue and that it also is a side effect of many of the medications. How do you deal with this?
It's true. Fatigue is a big one. There's a lot of other symptoms like sleepiness or dizziness that you're like, I don't understand. This goes with the disease, but also goes with the medication side effects. And that is the challenge for us. Because, just with the disease, let's say you're not on any medicines, right? Fatigue can come with the disease, and there is no medicine for fatigue, right? And so we try and tackle it in different ways, right? By saying, let's focus in on the sleeping. Let's make sure you're sleeping extremely well and you have a good quality sleep overnight. Are you exercising during the day? Are you taking a nap in the middle of the day, which for a lot of people is really helpful for the fatigue? Let's look at your other medications. Let's look at the ones we're using and adjust them, right? So it is a constant moving, moving goalposts as far as trying to figure out what's doing what and adjusting different things till we do get the fatigue better. It is a tough thing. That fatigue by itself is a very tough symptom to treat, but it is something that we try indirectly to help by adjusting different things.
Okay. My husband had Parkinson's. As the medication would wear off, he felt the same as he did after taking the next dose. Is that unusual?
So again, maybe I don't understand the question fully, but what happens a lot of times is so you're taking a dose of medicine, right? It peaks in your system, you feel good, and then it starts to wear off, and you feel it wearing off. It's not working anymore. And if you take the medicine, and this is all based off not just what you're doing, but what your doctor's instructing you. But if you're taking it too late and the dopamine levels are going down, it's going to take a while for those dopamine levels to get back up. And so we're trying to mimic what the brain typically does without Parkinson's, which is a constant level of dopamine throughout the day all the time. And so that's why the medicines should overlap. Now, it's hard to find out when that overlap period is so that we're not letting the dopamine levels drop too low before the next dose. And then it takes a while for them to kick back up, right? We want to hit the next dose should be just as the medicine starts to wear off in your system or the dopamine levels go down, so you never feel it, right? That's the goal is never to feel like you wear off. It's just sometimes people need it very frequently throughout the day to avoid that. And that's why we're coming out with some of these new advanced therapies for Parkinson's to keep those levels of dopamine up throughout the day.
Fascinating. Wow. What is the male-female ratio for Parkinson's?
So we used to think it was definitely more of a male dominated disease. Like I think one of the old estimates, maybe like 30 years ago, was like 3 to 4 to 1 as far as male to female. That has come down over time, and I think it was probably an overestimate at that time that really it's probably 1.5 to 1, meaning there's probably 50% more often in males, but it's still fairly close. It's not like the 3 to 4 times as much.
Okay. After 7 years since his diagnosis of PD and LBD, my husband is a poster child for the advice that exercise is medicine. He's doing much better physically, but declining more cognitively and with memory. Is this difference in progression common? He also takes several PD and LBD meds that seem to be working well.
Yeah, so, and again, for my talk, I think it's always a good idea to get that answer, just because it adds to confusion when we start talking about people with PD, Parkinson's disease, and LBD, Lewy body dementia. Usually it's going to be one or the other, right? Now, many people with Parkinson's do eventually develop dementia, and we just call that PDD or Parkinson's disease dementia. But again, besides that point, it is common that yes, exercise is the best thing to slow down the progression, to improve you physically, and often, most of the time, to ward off dementia too. But that doesn't mean stop it, right? So eventually it does start to creep in and become more of an issue. And it can be hard to treat, but that is something that we expect that even with people who do great with exercise, eventually the cognitive issues can come into play.
Okay. Does delaying treatment for Parkinson's have a negative effect on progression of the disease?
Yeah, so this is a really hot issue, I think, for all of us, including me. I was on the guidelines back in 2021 about this question because we've known for a while really the answer, although it can be sometimes confusing. We used to take the approach, well, we want to save the medicine, quote unquote, for later, right? Because if you start it too early, then your body gets used to it, right? That is not the case in this disease at all, and in fact, quite the opposite. What happened and what we found we were doing, which was really bad for patients, was holding off on it and not giving their brain and their body what it needed to function physically. And what would happen is they would eventually become desperate. We would start the medicine, but it would be too late. The medicine doesn't work as well later in the disease, even if you delay the start, right? Another way to put it, if you duplicated your body, right, and one of you said, "I'm not taking meds for 5 years," and the other one said, "I'm taking meds right away," well, in 5 years, the meds are going to work or not work the same way, right? So, if anything, we are much more aggressive with the medications because we know that, let's say you are struggling physically, right? And we gave you and your brain more dopamine, just like any other vitamin, right? If I said you have vitamin B12 deficiency, I wouldn't say, but we're going to hold off on giving you vitamin B12. You'd be like, no, I need that. Like, I want my levels back up. So, same thing with dopamine. If your brain and your body needs it to function physically, well, many people will say, you know what? Yeah, I used to do these laps around my house or around my neighborhood, and yeah, I'd always get like tired after 2 laps or feel like I just couldn't do that extra lap. Then I started the medicine, and I can do like 3 or 4 now, right? So, in turn, by being able to physically function better and knowing that more exercise will slow down the progression, then indirectly we're helping the people to live longer and slow the progression by, if anything, being aggressive with the medicines and starting them earlier, right? Now, there are a couple things that we avoid because we know they're problematic. High levels of medicine, like high levels of levodopa, but as you saw from the list, we have so many options now that we're not desperate for high levels of levodopa, right? So we can avoid that. And then, yes, I mean, if we can if there are symptoms that are truly not bothering you, like there are a lot of people who have tremor who could care less about their tremor, that just doesn't bother them, then no, I'm not going to just start something just because it makes me feel better. But if you're having slowness and stiffness and your walking is affected and your balance, those are times when it's like, let's use the medicine so that you can function better.
Oh, all right. Well, it looks like we have got through all of our questions. Um, uh, Justin, thank you so much. All of this is such incredible information. It's always a pleasure. And I guess I'll remind everybody that this is being recorded and we'll have this posted by Friday. Oh, uh, one more question. Is there a Parkinsonian personality?
No, there's not a Parkinsonian personality. There are some. Um, changes to someone's demeanor that can happen with Parkinson's that you can become more apathetic, right? A lot of people equate that with depression. Not always, right? Some people will say like, yeah, I'm not really sad. I'm not really happy either. I'm just kind of here, right? And so that can give off a level of change in personality, but it's more just apathy. Sometimes it is depression, sometimes it is anxiety, sometimes it's a lot of different things. Sometimes people, and a lot of people who quote unquote sometimes look good, right, physically, will say that they just don't feel good because they have all these little kind of issues going on where, in and of themselves, maybe they're not big, but if you have like 10, and I'm making up numbers here, but if you have like 10% constipation and 10% depression, and you have 10% fatigue and your tremors getting worse and you're more embarrassed by it, like all these things start adding up where again, not one thing is super bad, but it all adds up. And so that's when you get people who are like, what, I know I may look good, but I just don't feel good. I don't feel like myself. And it's hard for them to describe, right? Because it's not just one huge thing that's like, oh, it's definitely, this, like my, whatever, urinary issue. It could just be a million things. And so that's why it can affect someone's outlook on life for sure. And we do all take that all seriously, but it doesn't quite change like who you are, who you're at your core. It doesn't change that.
Uh, and if you have time, we have a few more questions that came in. Let's see. We have you had mentioned that cancer or other conditions can affect the progression of Parkinson's. Could you comment a bit more on this?
Yeah, I mean, I think that the best way that I describe it, and there's no easy math to this, right? But the best way that I think about this, and I tell patients to think about this, is imagine your body is trying to fight off Parkinson's, right? Like it's an infection, right? It has to devote all of its time and attention to, fighting off the Parkinson's. If it has to devote its attention to any other stressor, physical stressor, right? An infection, a medical issue, cancer, dehydration, what you're eating or drinking or not eating or drinking, anything else, or psychological stressors. And we see this all the time too. A move, right? Stress that comes with that, a loss of a family member, even things that can be good, like retirement or whatever, those things, that's when your brain gets diverted its attention and it has to deal with other things. And the disease is allowed to go, quote unquote, unchecked, right? That's kind of the best way. Now, many times it's just temporary, right? You may have a cold. It feels like the flu to you. Your tremors are getting much worse, your balance getting much worse. But as soon as you get over that cold or that flu, you get back to normal, right? So it's not necessarily like the progression worsen and there's nothing to stop it. But then there are times that it can worsen and you can establish a new baseline. We see this often after surgeries with general anesthesia. Again, major medical issues or major injuries or whatever, right? Where, yes, we hope that you bounce back, but you may not bounce back fully to 100% where you were before. So that's kind of the best way I can answer that.
Gotcha. Okay. And then there was a follow-up to the Parkinsonian personality was I meant people who get Parkinson's, are they low-key people to begin with?
Yeah, sometimes it seems that way, right? I get a lot of patients who say, "Oh, they were always quiet, or they were always slow. They always took their time." We don't necessarily know that that's a good tie-in. Plenty of us can think of plenty of examples of the opposite happening, right? I think it sometimes is more. I think that, and again, I can't say that this is everyone, right? But if you've been developing the disease over a long period of time, right, you start to develop into that kind of slower, more low-key person, right? And so, again, I know that's not the same as what I think you were alluding to, but it is, I don't think it's something that just attacks a certain type of person, right? I think it is, and again, there may be certain types of people who put themselves in certain circumstances over life, right? Whether it's the jobs that they pick, or the places they choose to live, that maybe is more low key, right? And again, I'm just guessing at this, but it is, we haven't seen anything that it's like only this type of personality or only this type of person gets it. It's really, I think those are all just coincidence that may allude to a certain type of lifestyle that leads to that, but I think I'm going too far. So
And looks like last thing I have on here is just a comment from Tom. Thank you for the session. This has been very informative and very personally helpful. So,
great.
yeah,
That's why we
I
do it,
agree.
right?
Yeah, I agree. Justin, you're always fantastic. Thank you so much. All
Thank you,
right, well,
Michael.
we'll record this and hope to see you soon, Justin, again. And
Thanks.
everyone, there'll be a survey afterwards. And thank you very much.
Good night,
All right,
guys.
have a good night.